Good morning and welcome to today's webinar, which is entitled Global Action, Improving Health Outcomes for Sickle Cell Disease. I'm Alexis Thompson and I serve as the President of the American Society of Hematology, or ASH. I'm going to be joined on today's webinar by Jalili Ojodu, the Director of Newborn Screening and Genetics at the Association of Public Health Laboratories, and Dr. Kwaku Ohene Frimpong of the Sickle Cell Foundation of Ghana. We welcome your questions, which we hopefully will be taking at the end of the webinar using the Q&A session on your computers. We invited you here today on World Sickle Cell Day to bring attention to the burden of sickle cell disease in low-resource countries, specifically in sub-Saharan Africa, which shoulders 75% of the global burden of this disease. I'm going to cover for you what is sickle cell disease, the state of sickle cell disease both in the U.S. and globally, what organizations like ASH are doing to address these challenges, and what steps are needed to improve health outcomes. What is sickle cell? Sickle cell is a disease caused by an inherited mutation or error in DNA that results in the production of a defective sustains us. It's typically the substance inside red blood cells that carries oxygen. In individuals with sickle cell disease, this mutation under certain circumstances results in their red cells becoming misshapen. Instead of having a normal soft round shape, that they are often abnormally shaped, looking more like a sickle or a banana, and are far more rigid. This has specific consequences in that these cells cannot as easily traverse the smallest blood vessels in our body called capillaries. And the buildup of those cells in these small blood vessels can result in a number of the sickle cell complications, the signature complication being pain. Repeated episodes, though, of these blockages starve organs of oxygen and can ultimately lead to complications that lead to damage to a number of the organs in the body, including the brain, the lungs, and the kidneys. This also likely results in a shortened lifespan for individuals with sickle cell disease. Before I move on, I want to mention a few of the initiatives that the American Society of Hematology, or ASH, has taken on in the last 2 years, specifically launched as a result of our call to action on sickle cell disease. We've taken on several projects to accelerate progress both in the United States and abroad. A few of these projects are mentioned on this slide. They include a broad effort in education and training focused not only on providers but also on patients. We've also launched an ASH registry, which will hopefully underlie ultimately the development of a clinical trials entity. And we've also helped to convene the Sickle Cell Disease Coalition, an important town square which allows a number of like organizations to come together to try to improve outcomes in sickle cell disease. If you'd like to learn more about these and any other sickle cell projects, please go to ASH's website, which is hematology.org/SCD. As part of our call to action 2 years ago, ASH issued a report on the state of sickle cell disease that they evaluated the state of the disease in 4 areas: training and education, patient access to care, treatment, and global issues. This exercise allows us to celebrate both the progress we've made as well as help us to focus on areas where we need improvement and to set a path forward. We've learned a lot about sickle cell disease in the United States, and we hope to learn more because we realize that this will be fundamental for us determining next outcomes. The slide that's up gives you some very important demographics about sickle cell disease. These are estimates, so we believe in less than 1 in 400 births of African American babies in the United States will be a child with sickle cell disease. We estimate that there are about 100,000 individuals with sickle cell in the United States, but we know very little about what their daily lives are like. Because there are 3 to 4 million Americans who have sickle cell trait, we know that it's likely that there will continue to be children who are born that inherit sickle cell disease. Currently, only about 20% of providers say that they're comfortable taking care of sickle cell disease, so there's clearly work to do. We know that sickle cell patients do not have a normal lifespan and that 1 in 3 will have a brain injury as a result of chronic sickling. We know that there are a number of treatments, that there are very few treatments that are available for sickle cell disease. In fact, at the current time, there are only 2 treatments that are approved by the FDA in the United States. The only curative approach that has sufficient data to help us is stem cell transplantation. Screening has now become universal in that all infants in the United States, regardless of race or ethnicity, are screened for sickle cell disease, and that's resulted in over 90% of American children surviving into adulthood. We know, however, that this is not the same globally. There's definitely a need for more to do in the United States, but certainly more in the United States. As you'll see outside the United States, the number of people with sickle cell disease is expected to increase, and we expect it to increase by 30% by 2050. And while I mentioned to you this fairly optimistic number of over 90% of children in the United States surviving into adulthood, could not be more extreme in terms of the difference in Africa and elsewhere, where over 90% of these children with sickle cell do not survive, very few surviving beyond their 5th birthday. Again, we mentioned before that 75% of this burden falls to sub-Saharan Africa, which is the focus of efforts by many, including the 2 people that I'm sharing this call with. So for this World Sickle Cell Day, I'd like to introduce our next speaker, and that is Jalili Ojodu from the American Public Health Laboratories, which is a member of the Sickle Cell Disease Coalition, and one of the groups making fantastic strides in sub-Saharan Africa. Jalili, the floor is yours.
Thank you, Dr. Thompson. Good morning, afternoon, or evening, depending upon where you are in the world listening to this webinar. I'd like to thank ASH for their support. And like to follow up on a number of things that have been discussed earlier on by Dr. Thompson. The slide that is on now currently talks about our mission and vision at APHL. We have a role in shaping public health laboratory activities around the nation here in the United States, but we also have a global impact as well, which I'll touch upon in a minute. Next slide, please. So you can skip this because Dr. Thompson talked a good bit about sickle cell disease. I will have the opportunity this afternoon or this morning to be able to spread the gospel of newborn screening in reducing the burden of sickle cell disease in places where sickle cell disease is endemic the most. As Dr. Thompson said, 75% of newborns born around the world, or especially that have sickle cell disease, are in sub-Saharan Africa, where there is no comprehensive newborn screening to actually detect and make an early intervention on newborns. Newborn screening helps identify newborns that have any form of these kinds of genetic conditions, and we are able to make a positive impact screening early enough to be able to make a difference in the lives of newborns with any genetic condition, but especially in this case, sickle cell disease. Prevention, we're able to prevent a number of occurrences of infection through penicillin prophylaxis and pneumococcal vaccination. Also, we are able to educate the family on a number of signs and activities related to sickle cell disease. Next slide, please. So in spreading the gospel of newborn screening, I wanted to highlight the fact that newborn screening is just not the test. It's, in fact, in considering newborn screening, the laboratory test is the easiest part. It's making sure that all of the components of newborn screening are not only addressed, but are implemented, and the infrastructures are there, from, the testing of the baby, screening of the newborn, following up on those affected cases, making sure that there is an available medical home or somewhere that a newborn can be followed up on, and effective management of all of these kinds of activities. These are the kinds of things that we've been working with a number of countries around the world, especially where newborn screening is not done on a population scale. And so take-home message from this is newborn screening is certainly more than the laboratory test and consists of all of these other activities here. Next slide, please. So at APHL, we have worked with a number of countries, not only developing countries, but developed countries around the world in initiating and working on a number of pilot studies. We've worked in collaboration with a number of partners, including our funders, the Centers for Disease Control and Prevention, in providing training opportunities for laboratory staff from any one of these countries, from Ghana to Tanzania and to Nigeria, in helping them understand how population screening works. And it works both ways as well. Not only do they get the opportunity to come here and train, we have had the opportunity to go to a number of these countries to be able to help them understand these kinds of initiatives as well. And not just the testing as well. On the right-hand side of the picture, we also work with these countries to be able to understand how the importance of the collection of the samples, because you want to be able to make sure that you collect it well the first time. Next slide, please. So there are a number of educational resources that we have really available on our website, including one on hemoglobinopathies here, current practices for screening and confirmation and follow-up. This is in partnership with the Centers for Disease Control that we developed this guideline that we believe will be very, very applicable to a number of folks that are developing newborn screening initiatives around the world. And also spreading the positive stories about the positive effects and accentuating those positive stories about newborn screening and how it saves lives. And so both of these educational materials, among other things, are freely available on our website. Next slide. So in collaboration with the Sickle Cell Foundation of Ghana, which you will hear from the president in a minute, we also developed a curriculum and implemented it twice already in Ghana on sickle cell counselor training and certification programs. These are the names of collaborators around the world that we've worked with to be able to implement this. We're proud of it, and this is transferable not only to any country in Africa, but we believe other countries in helping not only dispelling any of the myths about sickle cell disease, but helping families better understand those implications in moving forward. Next slide, please. So again, this is just a picture of a number of the healthcare advisors and community members and leaders in Ghana that we helped shape and help develop the guideline on sickle cell counselor training program. Next slide, please. And then this is a picture of actually I think the first cohort of counselor training, counselors, nurses, and families as well, that were able to shape, as we hope in the future, of sickle cell disease and education and moving forward. Just to round up here, a number of other global activities that we've embarked on: technical assistance, a number of twinning initiatives. We have been able to provide resources by connecting vendors to a number of countries around the world, and access to guidelines and practices and resources related to sickle cell disease around the globe. And next slide, please. So at the end of the day, it's all about saving lives. As noted, there are a number, hundreds and thousands of babies that are not screened for sickle cell disease around the world. And we want to be able to make an impact in moving forward. And so next slide, please. We would love to encourage a number of folks in power, whether it's lawmakers, legislators, or ministries of health, in not only investing in the infrastructure for sickle cell disease, but also helping, at the end of the day, saving lives and reducing the burden of this condition. So with that, I would like to thank Ash again and pass back to Dr. Thompson.
Thank you, Jalili. Next, I'd like to introduce Dr. Kwaku Ohene Frimpong, who in fact is joining us from Sub-Saharan Africa from the Sickle Cell Disease Foundation of Ghana. He's going to talk a little bit about his work in the region, as well as some of the myths that continue to exist about sickle cell disease.
Thank you very much, Dr. Thompson, and to also thank Ash for inviting us to participate in this, and good afternoon from Ghana. As was said before, sickle cell disease is a major problem in Africa, and just to compare two countries that have sickle cell disease as a major burden, we all know that Nigeria is the largest country in Africa in terms of population, and Nigeria has the greatest burden of sickle cell disease in the world. It is estimated that about 150,000 babies are born every year with sickle cell disease in Nigeria. Ghana is a smaller country, but we have about 15,000 babies born a year, and this is the case in most of sub-Saharan African countries. Also, a lot of the progress that has been made in sickle cell disease outside Africa, unfortunately, we're not seeing that yet. Jalide just mentioned newborn screening. Ghana established a newborn screening as a pilot program back in 1995. But even up to this point, we are only able to test about 4% of the babies born in Ghana because of government resources and the inability to scale up the screening. One of the problems in Africa in dealing with sickle cell disease is that it has such a high toll of mortality in the young children who have not been diagnosed. And so most countries in Africa actually don't have very good statistics of the impact of sickle cell disease on childhood survival. And so while the World Health Organization has estimated that between 5% and up to about 16% of babies born in Africa die from sickle cell disease by 5 years of age, most of our countries don't have any of these statistics. Because if you don't screen them at birth and they die from very short illness, in much of Africa, that is always assumed to be due to malaria. So the lack of data also slows down the ability for public health services to devote attention to sickle cell disease. So in the past, we used to say that people with sickle cell disease, about half of them would not live to be adults. And clearly, in Jamaica, in the US, and much of Europe, children with sickle cell disease are living way past 90% into their 20s. But Africa, we're still lagging behind, losing so many of them before they even get to 10 years of age. Next slide, please. So in Ghana, we have been working very hard to try to implement some of these services. And like most developing countries where there's not a lot of knowledge, modern knowledge about sickle cell disease, we meet many, many challenges. The government of Ghana took over the newborn screening program that was funded initially by the National Institutes of Health as a research grant. We had always hoped that after the years of the pilot study that the government would be able to expand the program into a national program, but that has been somewhat slow. Ghana, just as well as Nigeria, have actually had sickle cell disease programs for a very long time. And although we haven't been able to scale up these services to meet the needs of the country, it's gratifying that the major medical centers in both Nigeria and Ghana have had sickle cell clinics for quite some time. Newborn screening is only beginning in Nigeria. In Ghana, as I said, we have newborn screening, but it hasn't been up to the scale where it needs to go to. Both countries have actually developed guidelines on managing sickle cell disease in our environment. Nigeria's has been a national policy for some time. Ghana's is going through field testing at the moment. As Jalide said, we have developed genetic counselor programs to train nurses and others on how to interpret results of sickle cell screening so that families can understand how come they have their condition and their children have sickle cell disease. Even now, hydroxyurea, which is a new medication to much of Africa, only about 1% of patients in Ghana have access to hydroxyurea, and I would imagine the same thing in Nigeria. Relatively inexpensive in other parts of the world. In Africa, hydroxyurea is unaffordable by most families. And so if countries and insurance companies don't cover hydroxyurea, there's no way our families can afford it. Now, we mentioned the stigma attached to sickle cell disease. If you don't understand modern genetics, it is hard to comprehend how children in one family may be born and lost very early in life or developed this very painful disease. So often people think that this is a curse. It's something that the family has done that they're being cursed for. Somebody wishing them evil has cursed them with this disease. So witchcraft has become part of the background to sickle cell disease. Unfortunately, even well-educated Africans sometimes carry this burden of thinking that people with sickle cell disease, there's something wrong in their family. And because of that, even wealthy and sometimes very educated Africans don't want to publicly speak out about the fact that they have a child with sickle cell disease or their family members have the disease. This sort of hinders our ability to reach government. I've worked with people who are professionals in the Ministry of Health in Ghana who have children with sickle cell disease but would never publicly talk about it. So it's very difficult for patients who don't have such a strong voice to become advocates for themselves. We are working very hard in Africa as elsewhere to try to improve the lives of sickle cell disease patients. And we do encounter some successes. Through newborn screening, we have children who are now 22 years old, who are the first cohort that we screened. Some of them, a few of them have gone to college. Many of them are doing well, and they're quite confident that they can lead regular, normal lives as long as they come and get the care that they need in the established sickle cell clinics. You know, recently I made several appearances with a young lady in Ghana who is rather plump, and doesn't fit the picture that most people in Africa think people with sickle cell disease have. They expect that all sickle cell patients are very skinny and look like they're always sick and need help. This young lady that we met when she was 11 years old, when we started a clinic at one of the hospitals in Accra, graduated from the University of Ghana a year ago with a degree in biochemistry and molecular biology. And now when I make appearances with her, they just say they don't believe that she's a sickle cell disease patient. So that's a success story that she can tell everybody else. Occasionally, we also have stories that are sad. There's a boy in Ghana that had just made me sad for so long. He, at around 3 years of age, developed a stroke. And in other parts of the world, stroke is preventable with studies that we can do and place children on chronic transfusion. This boy has had multiple strokes, started on transfusion. The transfusion program didn't go well. And now here he is out of transfusion. He's had several strokes. So this is another sad story. But we're encouraged by the successes because we're seeing more and more of it. And the more we work to educate our people, to develop the medical systems and get support from our governments, we think that we too can improve the lives and outcomes for people with sickle cell disease. Thank you. I think I go back to Dr. Thompson to sum up for us.
Thank you so much for your overview. It's clear that we have much work to do in terms of combating myths, combating stigma, addressing myths. And among those things are going to be 2 new resources that will be made available today. One of the documentary of Dr. Ohene Fremhon continuing to show many of the things that are being done in sub-Saharan Africa and in Ghana to address these issues. There will also be a public service announcement that will also be made available. You can view these videos on the Sickle Cell Disease Coalition's website, which is scdcoalition.org/global. Please watch and please share them. So thank you so much for joining us for this webinar. In summary, we need to prioritize the design, testing, and implementation of sustainable care and pain management approaches for countries with limited resources. This means establishing or expanding newborn screening and early intervention programs. It also means increasing education of governments about the importance of screening and caring for people with sickle cell disease, and improving global access to care and education for providers. We're running short on time. We've, I think, had a fantastic discussion today. But for those who have additional questions, please continue to send them in or email us at press@scdcoalition.org. Again, we hope you will go and please view the 2 videos as well as please to send your questions. We look forward to working together with you for next steps and to hopefully by this time next year see major progress in improving outcomes for individuals with sickle cell disease. Thank you. Good afternoon.